sit down and start? Hello. Karibuni kumbele. Please sogeni tuweze kusikia vizuri, and then wale wanaokuja tutakuwa tunachia nafasi nyuma. We are about to start in 2 minutes. Karibuni. Thank you very much. Yupo? Ameshajoin, eh? Okay. I think we're all set. It's 2 minutes before time, but we'll start anyways. Welcome all of you, and I'd like to thank you very much for taking time to come and join us in our Amref support program. As working time at this somewhere. Public health, 20 years experience working with public health issues and in areas of program design and overall project management. At her current role, Dr. Aisa is the head of programs at Amref Health Tanzania, and in that role, she spearheads and oversees almost over 20 donor-funded projects within Amref, and she has in HIV and AIDS prevention and treatment, maternal and child health programs, youth sexual reproductive health, and published a lot in reputable journals. So I have the honor to welcome Dr. Aisa, who is going to be our moderator today, and we are looking forward to a very exciting discussion and deliberations. Karibu sana, Dr. Aisa.
Ladies and gentlemen, good morning to you. As I've been introduced by my colleague, Dr. Frida, my name is Samuya, Head of Programs. I feel very honored having this opportunity to moderate this very important issue on health. So let me first start also introduce our esteemed speakers. I will start with there's Dr. Ntuli Kapologwe, he's a medical PH, and he's also University of Dodoma. He has conducted an implementation study embedded with on direct health facility initiative, system performance in primary public health facility. He was once a Bahi DC, he also became the RMO of Shinyanga, and since January 2017, he has held the position of Director of Health, Social Welfare and Nutrition Services at the President Office of Regional Administration and Local Government. And then we have Dr. Meshak Chinyuli, who will be online. He's a medical officer, currently serving as a national coordinator at the Ministry of Health, Community Development, Children and Services, Health Promotion Sector. Karibu, Dr. will be with us physically, but will be. And we also have an honor to have Dr. Florence. Also holds a degree in medicine, master's in public health. She also has a diploma in the palliative care. She's the currently director of Amref Health Africa in Tanzania, and even before assuming her role, she held various positions at Amref, including being a country director of Amref Health Africa in Ethiopia. And Florence is also served as the member, director of Tanzania, a member of Global Women Network, a member of Board of Directors of White Ribbon Alliances, and also a member of Board of Guarantee Bank in Tanzania. Karibu, Dr. Florence. And we have also the honor of Dr. Musiba, a graduate from Muimbili. He's a medical doctor at Manyamala Hospital, also in charge at Kambarage Health. And then currently he is in using this. He is also of steering committee of a maternal child improving project, Zazuzima project in Simiyu region. And also have Dr. Eric Van Praag, the medical doctor, public health, clinical and epidemiological expert. He is a public health veteran and father of community-based program in Tanzania. He was a country director of FHI 360 in the past for many years, and currently he is a senior regional technical advisor of FHI 360, community care advisor at UNICEF, member of technical review panel at Geneva, and member of International Advisory Board of CET UK, and a fellow tropical medicine and hygiene. And last but not least, Mr. Sabor Eliza. Sabor Eliza is a trained community health worker with over 15 years working as a community health worker at Endulem Ward in Gorogoro district. He has also so much expertise on health promotion, identification of disease outbreaks in the communities, and has been a great linkage between communities and formal healthcare systems. Karibuni sana all the speakers, and please clap for them. So, we are all aware that community-based health system plays a very bigger role as we are moving from the era of health system strengthening to the era of universal health coverage. And we know that since independence, Tanzania upheld the momentum of health for all. This is the time when the first village community-based health workers were trained and placed in various rural areas in Tanzania. And also following the Alma Ata Declaration in 1978, the government of Tanzania continued the momentum to ensure there is community awareness of health issues, community mobilization, community strengthening systems, to also establishment of village health committees. And most often, community health workers were relied on delivering of assortment of health services and mostly linking directly communities to the formal healthcare system. So recently, there have been a resurgence of global attention to community healthcare workers. And they recognize them as an integral part of health workforce is needed in the country to achieve their health outcomes. And these CHWs are now being considered as the world's most promising health workforce resource in terms of enabling health systems resource-constrained settings to be able to attain the universal health coverage, which is now propagated by the Astana Declaration to accelerate the SDG by 2030. So we commend the government of Tanzania to start the community-based health program for of health for all. We know that the Health Sector Strategic Plan 5 further promotes volunteer work and further strengthen community health systems. And we are now in the verge of also finalizing the operational guidelines, which we are looking forward to have them being rolled out in coming years. So without further ado, we are going to hear more details on this exciting topic from our speakers to break down these community health work systems and how it contributes in improving outcomes. So I will start with Dr. Meshak Chinyuli, who is online. Dr. Meshak, I believe you can now join, and I have a question. So is Dr. Meshak available?
Yeah, thank you very much, team. I'm following available.
Okay.
Thank you.
Okay, now, so Dr. Meshak, Tanzania has made milestones, TBHC policy and operational revised to align with the updated health that the ministry will outcomes, especially the community health.
Thank you very much for this chance to be one among the members to put this topic on the table. I'm getting a bit to get you because of some issues, but I hope the team is getting me well. And direct would like to go to the point of discussion as stipulated by the moderator. It's true, long history of implementing community-based. This is back since the independence, and during those time, the implementation of different community intervention were a bit vertical. There was an intervention by NGOs, other intervention were implemented by vertical. But it was a bit difficult to go to this intervention and make a consistent way of implementing this community health intervention. So by observing this, Tanzania Bureau Ministry of Health on 14 decided to come out with a policy guideline that is stipulated the modality on how we of the country can implement this community-based intervention. And this policy guideline on 2017, we developed the so-called implementation design, which was designed to implement the policy guideline of 2014. So in this policy guideline for 2014 and this implementation design of 2017 had some issues that we were aiming in order to strengthen and stabilize this community health intervention. And on doing that, we developed also the strategic plan of community-based health program of 2015-2020. But during the implementation of this document, as we know and remember, in this policy guideline, specifically in human resourcing, the policy guideline was pointing that to have the community health workers that are trained for 1 year in our training institution. And this community health worker was intended to be paid as the government employees. So during the implementation, we had some difficulties in this. So the Ministry of Health, PRH, and other institutions decided to make a kind of assessment to see how we can come out with a realistic kind of policy that will incorporate all the issues in a realistic way and implementing this community intervention. So we made this, and on 2020, March, we had the new policy guideline that we are replacing the policy guideline of 2014, and also we are finalizing the so-called national operational guideline, which is going to replace the so-called implementation design of 2017. So this document, we need a way that is going to address all the issues that we had and that were a bit difficult to implement in the document that 2017. So in short, on this policy guideline of 2020, we have some issues that we pinpointed in this policy guideline to see how we can keep on strengthening and making our community health intervention to be at least consistent throughout the country. So this policy guideline of 2020 had about 7 areas. That is trying to pinpoint some issues pertaining the implementation of community-based services. Area number 1 is human resourcing. So in this new guideline, replacing that community health workers that were mentioned in policy guideline of 2014, Now we decided to have the community health workers, which are volunteer, and that community health workers are nominated at the Kitongoji level. Before we had the system of having the community health workers from the village level, and the police was directing that have 2 community health workers in each village. So addressing that issue, currently our police guideline is directing us to have the community health workers at Kitongoji level. For the rural areas and for the urban areas, this Kitongoji is going to be replaced with So we are going to have the community health worker at that level. And also, we want to make our intervention to be consistent throughout the country. So we also, in this area of human resource, we decided to standardize the training package. So currently, all community health workers throughout the country, after being nominated at the Kitongoji level, will be capacitated by using the standardized training package. So we have the package with 6 modules, and these 6 modules are standardized considering the level of the community health workers and the scope of work. So we will be delivering a standardized package to the community health workers. But also we decided to pinpoint the scope of work of these community health workers. We have mentioned the rules and responsibilities of these community health workers and the boundaries. So we have pinpointed the responsibility and what is the limits of the community health workers to perform the so-called community-based health intervention. But also we put the so-called identification mechanism. We have standardized the uniform so as to make the community health worker identified among the community members. But also we have so-called this and this will be standard and unique to every community health worker. The second area in this policy guideline is directed some issues pertaining to resource mobilization and utilization. Currently, we standardize the incentive for the community health workers, different from the previous type that every program had some standards of providing the incentive to the community health workers. So now we decided to standardize this, and also the policy is directing the modality of financing these community health workers through the existing system. So currently we are going to provide the modality for financing these community health workers by using the so-called direct health facility financing. So the funds for these community health workers from the donors and other sources will be directed to the facility that these community health workers is serving at that locality. So the facility will be able to provide this to the community. This was to add the sense of responsibility among the community health workers, and we know the immediate supervisor of these community health workers, specifically in some technical issues, is in charge of the particular facility that this community. But this is trying in integration of community-based services. Now is directing us at least to integrate this community health worker, this community health intervention to be served by one community health. We had the community health workers working in different thematic areas. We had other community health workers that are working specifically on reproductive health, others were working specifically on HIV. But now we want to integrate these whole services and provide services in integrated manner. Health services oriented issues, we want to make this to perform some of the social welfare related issues. So we'll be having one figure capacitated to perform this issue in integrated manner and ensuring that we are capacitating the community health worker so that to have the one figure with capacity of performing these all issues. Integrating community health workers issues. We have also direct issues on participation in community-based health program. We did this going on. Many of the community interventions and community-based health programs were donor-oriented or donor-dependent. So now we have provided some modalities and issues to make the community itself to feel community in their areas. This, we believe, will make this program to be at least sustainable and not being donor dependent as before. So now we expect to count all times of the year. This policy guideline, there are some issues pertaining the intersectoral collaboration. So we want now the community health intervention to see how we can collaborate with other sectors so as to ensure that we have the intervention workers and community extended workers, officers and other officers in the community. Sure that effectiveness of community intervention are provided. But lastly, in this policy guideline, there are some issues pertaining the monitoring and evaluation issues. So currently, we want at least to have the modality of conducting this monitoring and the evaluation issues, all community health intervention. By doing and now this improvement will be used by the community health workers at the community data register. So the community health workers will be using this improvement.
Thank you very much,
and collecting these community data monthly in the facility, and then facility will integrate this data and uploading this data to the attention as we are expecting to do. So that is a summary of the issues that we are summarized in this policy guideline and operational guideline of 2021. And this we did this so as to see how we can I beg to submit. Thank you.
Thank you very much. That was a and implementers, the government implementers, the pure large, and we have honor of Dr. Ntuli here. So Dr. Ntuli, we acknowledge the UHC efforts that are being leveraged at local government authorities. We want to get your perspective on how do you envision the realization of an effective community health system, especially through the CHW card, and what to sustain for better health outcomes. And also on top of that, we'd also want you to comment on the role of the village health committees and the health facility governing bodies, the DHFF contribution in sustaining the community health workers and community health systems now as we are moving to that era. Karibu.
Thank you very much indeed. And really joined with other 4 community health workers, starting with Florence, Eric, Liza, and Arnold, So PRID being the main implementer of the community health-related interventions at the regional and district level, this is quite very pertinent platform for us to participate. We have been one colleagues from trying to address a couple of challenges affecting our community health system, which was the intention of the community health system. Initially, we had about community health workers with different names performing different duties. And we're happy that now we've come up with a guideline which was able to address all the challenges which we experienced before. So the universal health coverage, for us to be able to achieve universal health coverage by 2030, we need to have very strong community still to increase or accessibility to health services, but at the same time, they should be able to offer the social protection. So as far as the Tanzanian health system is concerned, so the community health system is part of the how the health system. So we know the structure of our healthcare system, which assumes the pyramid shape, whereby at the base we have the community, and then followed by the dispensaries, then health centers and the district alone, and this being the part of the primary health care. So having a strong community health system, that will guarantee us to be able to achieve the universal coverage. So how do we achieve, how do we arrive to? First of all, make sure health in the facilities. If you do not have a strong meeting between the two, and there is a gap and those who deliver services happy that line will be workers who are making represent their ideas, their views. But now we've incorporated them to be part of the Health Facility Governing Committee. So the new guideline, the community health worker, 1 or 2, they will be among members of the Health Facility Governing Committee for planning and budgeting, and also trying to approve the transactions that are conducted at the primary care facility level. So these important are to make our system sustainable. For us to have sustainable and resilient community health system, that's not enough. Health service, I declare, in these two, they are not together. Service individual community health workers, and also the resolutions out of those reports on a quarterly basis. So all of these are geared towards a sustainable. And the community health system, very much, especially during the COVID pandemic, as you may recall, initially we had actually the vaccine uptake, which was very low. So when we went to community sensitization, now we are closing to 900,000 people vaccinated in the country in the span of just 15. Constantly, during the Sinopharm vaccination campaign, because with the Sinopharm vaccination campaign, you have 2 doses and a span of 4 weeks. And you need your community health worker to be together with a vaccinator, because you want to remind come up with the second dose. As we using and having a strong community health will help us to increase the vaccine, COVID vaccine uptake, particularly for those vaccinated. Challenges. Committees are working up to the expectations. But with the new guideline, we believe we will be able to revitalize their performances, but we have been over-reliant to the Facility Governing Committee, the World Development Committee, but with this one, we believe, because we've outlined and we have really identified key figures who will be constituting the Village Health Committee. But village is not enough for now. You know, in Tanzania, we have 12,319 villages, and we have 64,300 hamlets. Our aim now is to go to the hamlets level, the vitongoji. It's where the people are. We really need to make sure that we invest at the vitongoji level. And in so doing, really, we'll be able to achieve the universal coverage. For now, what I would like, and that's my plea, is to invite each and every one of us to work together as pure right in making sure that we reach communities up to the household level through the hamlet level. Thank you very much.
Oh, thank you so much, Dr. Ntuli. That was a very good insight of actually what now is happening and how the PRLAG, which is a very important ministry, I think you all know, is the largest ministry in Tanzania. And it is the ministry which really touches the citizens themselves. So in terms of the health sector, we have Dr. Ntuli as an engine there, and of course many other working with him to make sure that these things which are being put in the policies are realized. And we have had a lot of initiatives and revitalization of these committee, village level, hamlet level, etc., which are going to be very helpful. So we have a DMO from Itilima, Dr. Arnold, who is actually the one doing the real thing. I mean, working and coordinating the districts in terms of seeing how these initiatives are being realized. So, Dr. Msiba, the CHW financial resources has been largely donor supported, as you've heard from even previous speakers. This is not sustainable, and given the country's vision to strengthen this platform, what can you say about the contribution of CHWs in improving health outcomes in your district? But also, can you also share the experience in terms of other avenues within your council that you put in place to financially support and sustain CHWs and community health systems at large? Karibu sana, Daktari.
Asante, Dr. Elsa. Yeah. First of all, I would like to thank you for the opportunity to participate in this forum along with other diligent speakers. The Tirima District Council, to start with, we have more than 738 community health workers with an average of 10 to around 15 community health workers working at our PICS facilities. And also, we have 102 community health workers which were deployed by the Benjamin Mkapa Foundation, working with the consortium with Amref and Direct Canada. And these 102 CHWs were employed in all 102 villages in our district. So these persons have been very useful to us. And to start in the year 2015, also we have addressed about the number of improvement in terms of district indicators. And to mention few in reproductive, maternal, and childbirth indicators, we have seen tremendous indicators. For example, in the year 2015, the number of maternal deaths were 10 as compared to 2020, where the death tolls of mothers have been reduced to 4 maternal deaths to the year 2025. And the first quarter of the July-September 2021, we have 1 death. And also, in indicators related to prenatal deaths, also we have seen improvement. Back in the year 2015, the numbers of prenatal deaths were reported below 40. And currently we have seen, with the engagement of CHWs, we have seen the number of prenatal deaths have been increasing. For example, the year 2020, we have reported more than 62. Not only that, but also we had a challenge of low number of the persons who tried in our health facilities. And below the year 2015, the total PD utilization or attendance was below 8,000 clients attending to our facilities. As compared to the recent number, where we see the number has been increasing to 106,000. So, and also we have a very important area of antenatal visits, and also with the engagement of CHWs, we have been the antenatal visits, especially the one below 12 weeks, has been increasing to 40% as compared to around 17.7% in the year 2016, for example. And also coming to the HIV AIDS indicators, and also we have appreciated significant improvement of indicators. For example, we have currently we have registered up to 36,000 clients who were tested for HIV. And thus makes us our facility to have now a total of around 40,000 clients currently in care from 2,000 back in the year 2016. And also another important area is on TB services, where we are working with a number of partners. Here we have FDH, where we have community based worker helping us in making sure that those people in the community suspected to have TB, they're brought to at the facility for proper care. So, coming from 50% TB notification in the year 2016, now we have managed to come to 167% of TB patients who are notified and being treated at our facilities. Achievement. Yeah. And also another area which is also very easy to us is sanitation and environmental health, whereby in the year 2016, the number of acceptable and quality dwells, for example, in our district was around 16%, and in the last 3 years, we've come to 44% in the year 2020. So that's a major contribution made by the CHWs, and we as issue of avenue to support the CHWs financially. Yes, we know we have fund sources which are used by our facility and council team in planning of the CHW activities. And with the recent document or guideline of CSHP, it has been alerted that 5% of the budgeted should be allocated for community health services. So this is very, very useful area where now the facility teams and the council teams must make sure that they plan and make sure that with the available financial sources in the country, the works of planned for the CHWs are being executed. So, for example, in our council, and we are planning from the cost sharings, out-of-pocket fees and insurance schemes like CHF and NHIF, and this we see as an alternative to support the CHWs so as to make sure that our council budgets are not directly going to be dependent to the donors. Yeah. Having said that, I would like to submit. Thank you so much.
Am I ahead? Thank you so much, Doctor. We had a very good highlights of what is happening at the district. He represents many other councils in different parts of the country where the district council management teams are working so hard to ensure they're coming up with innovation and the ways and systems to sustain community health systems, especially this very important cadre. We've seen the results of what they have done. We have seen the improved maternal health indicators, health promotion, uptake of services, TB case identification, HIV referral, etc., etc. So that's a very applaudable. Thank you so much, and congratulations, Dr. for a very good job, job well done. And I'm sure many people will want to learn more. We'll have time for questions later. So I will now go to Dr. Eric van Praag, our father of community health systems. With your extensive experience, Dr. Eric, and knowledge on community health systems strengthening in resource-constrained countries, how can you describe the functioning of community health platforms 30 years back compared with recent years? With aspects of these platforms back then, what can be reconsidered now and then? So 30 years ago, I know you were a young person like these guys here, very enthusiastic, digging down to find what we can do. So what's the difference now? What can you share from what was happening?
Thank you. I think I'd like to go back a little bit more than when I was young. Because health workers have a long history in Tanzania. Even before I was young and came to Tanzania, which was in fact in 1974. So I like to go back in history and look at community-based health services in the context of primary health care. Because primary health care is our umbrella, the essential care to be provided at the district level and below at a cost affordable to the people and to the systems and to the country, and really involving the communities. That is what primary health care is, and community care is part of that thing. Now the primary health care principles started in fact straight after independence in '61 and were strengthened very much by the Arusha Declaration in '67 as they reflect equity, involvement of the voices of the people, of the underserved communities in particular, under the motto, fighting poverty, fighting ignorance and diseases, as you all know very well. So in the year 1969, I was in fact in medical school, and many of you were schooling as well, or were in the conceptual phase or preconception. Now in 69, the CMO of those days, Dr. Akin, a very important person, a very good CMO in those days, he launched already in those years the policy of using what he called village health workers and TBAs at an annual RMO meeting. Even in those days, in 69, we had RMO meetings. That was the one in Morogoro in 1969. And he called on all the DMOs in that room there to ensure that training and supervision of that cadre, village health workers called, and TBAs, should be done under the auspices of the DMO. Not controlled by national level, not steered by national level, but really giving it back to the districts at that level. Now, implementation, of course, if you say so, is not that easy. As most of the DMOs, there were few these days, they were very overburdened with their jobs, they were not very much familiar with the public health, they were more medical oriented, and in fact it was only a clear policy 5 years after the Arusha Declaration in '72 that decentralization took place, and that gives a stronger mandate to those districts to make the resources available at the district level as the focus of development. That was 72, just after Arusha Declaration. Now during those 70s, I'm talking about also I came to Tanzania, a large variety of key community care, primary health care activities, almost all of them with village health workers, or community health workers as we call them now, were implemented in the communities and supervised by the facilities. And we had by these days in the facilities, we had MCH8s, if you remember, we had RMAs, we had MAs, medical assistants, and we had assistant medical officers, and a few DMOs, medical doctors, in those days. So the air task shifting, task sharing. So again, that is a very old concept. Task shifting, task sharing, MCH8s, RMAs, MAs, and our community health workers. That was the team to do it in those days. And in fact, very much like the situation today. Many successful experiences were documented in those days. They were initiated very often by mission hospitals and dioceses, but also by the universities. Mumbili had a strong project in Pagamoyo using community health workers. And there was usually, that is true, there was funding from abroad. It was not all the funding from coming bottom up, so to say. Very little involvement of international NGOs, like we have now the PEPFAR partners, they were not there. So it was a donor organization, a mission hospital, a diocese, and the office of the DMO doing this together. And I give you a few examples, and I should show you, sorry, I should have prepared that before, but I wanted to show you one book, what was published in those days, very few books. And in fact, we are now very lucky with Dr. Ntuli, who is preparing a new book, The History of Primary Healthcare in Tanzania, which will come out next year. But in those days, in the 80s, it was published on work done in the 70s by Professor Muhondwa from Mumbili, the social scientist there, anthropologist, Chris Hagenhoven, who took over from me when I was running the BTU in Pagamoyo from the Department of Community Health in Dar es Salaam, and Dr. Ruta Banzibwa Ngaiza, I don't know her, but they wrote this book, Community Health Workers, the Tanzanian Experience, Very important. Very few copies available. I hope you can find one, because it is very interesting reading, which really enlightens you where we are coming from. Now, that one of the things described there is this Hanang Village Health Project, started in '75 in Bahati, with Catholic missionaries linked with district officials, and handed over to the district officials in '83. Covering those days, we covered a district, but I'm trying to cover all villages, not taking one ward or a ward here and a ward there like we do today with our project. No, if you go for a district, you go for a district, and you try to cover it and you get an effect. That was very much the Hanang experience in those days that we learned from. Focus a lot on hygiene, integration, etc., nutrition, etc. Another example, more close to where we live here in Dodoma, was in Mvumi. Mvumi Hospital Community Health. In '75 it started, and after a number of years was taken over by Dr. Matomora. Not sure if you have heard about that name, but he was the person who took this idea of listening to the people from experiences in Latin America, from Freire. And he called that conscientization. So you listen to the people, you don't do something, you don't come with a guideline from national level. No, you go to the community and you listen, do nothing. Listen and experience, get that into you. And then you develop ways to address the issues. And that was very much done in Mvumi. In fact, until today, that was the outreach. It was more an outreach model, it's true, with the people they listen to, and the community health workers, village health workers in the Mvumi villages, and having a NURU, having a nutritional rehabilitation unit in the hospital to build that bridge, to build that referral bridge, in this case about malnutrition, between the community and the sick. Things went down, things went up and down in that Mvumi project, as there were issues with local leadership, there were epidemics, cholera came in between. There was the war with Idi Amin, which took a lot of young people away from the area, which were in fact community health workers, but it was revived in the early '80s by Matomora because of this aspect. Now in '78 then we had that very famous WHO primary healthcare meeting in Alma-Ata, where in fact from Dar es Salaam, Dr. Tarimo, he was Director of Preventive Service in the ministry, and Professor Honori, that was the Dean of Mumbili Medical Center, two of them, they went to the Alma-Ata, somewhere in Russia and Belarus, there to design this whole concept of primary health care and health for all by the year 2000 from a WHO. And they didn't have only just inputs there, they had in fact a major impact, the Tanzania contribution, because we were far ahead of many, many other countries. There are 2 or 3 countries in the world that has done a community health system like Tanzania did. And they presented there and they were really awarded for that. And then came this whole idea of health for all by the year 2000, essential health care, involving communities at the cost we can all afford. Further strengthening, when they came back, further strengthening of community care in the early '80s followed. There was the Maasai Health Services project, and we are very lucky that Liza, he came from that project, what started in the early '80s by Dr. Nangawe, again building on the needs of that community. And he had troubles because he found among the Maasai there were many hygiene issues, there were malnutrition issues, but there were also a lot of infertility issues among the Maasai women there. While the donor, and there was again an outside donor, was very much on promoting family planning. And Nangawa said, yeah, that's fine for those people who need spacing in their families. But many people are infertile. I can't promote family planning among those women. So again, the lessons learned is listen first to what your problem is and then develop your activities instead of the other way around. The last example I want to mention is Pagamoyo. That was where the faculty of the Department of Community Health, together with the Office of the DMO in Pagamoyo and the village health workers in the district, developed further the community health worker systems by making it a training ground for medical students. So the 4th-year medical students, and some of you are examples of this, they were put in the villages, a week in a dispensary village, a week in a health center village, and work with community health workers and the staff in the dispensaries to promote community care. It still somehow exists in Moombili, although it has been diluted a lot. But it was a very strong way for DMOs, like yourself there, to learn really the basic concepts of community-based healthcare. And in the ministry there was big support for that. Dr. Flavian Magare, he was then the first primary healthcare coordinator in the Ministry of Health from 87 till 91. And he developed as a coordinating mechanism that National Primary Healthcare Committee, where the multi-sectoral, where the Ministry of Community Development, Ministry of Education, and also the people from the university, and the people from CSSC from the, by that day it was called TEC and another thing, from the faith-based organizations were all coming together and give inputs to Magari in order to develop the more guidance, the national guidance for primary health care. So we learned a lot from those years, and I'm still just only in the 80s. But in the 90s something happened. The whole thing started a little bit to collapse. There was a decline in primary health care and community-based health services, basically because of financial restructuring modalities imposed to Tanzania by IMF and the World Bank. The vertical programs came up. It started with EPI, but then HIV/AIDS came with that very strict sectoral vertical program where you could work in that program but then do nothing else. So if you're working on home care for HIV/AIDS, you do home care. You use the AIDS dollar because it's a dollar meant for AIDS, not meant for measles, not meant for strengthening health services. And we are still suffering a bit from that. Although things are gradually widening and integrating a little bit more. But in the 90s we had that problem that the financial restructuring and the vertical segmentation of our approach in healthcare, which in fact was not only among the donors, but was also imposed to the ministry. We got an NACP, we got a TB unit, we got all sectoral units which were very well funded, while the health promotion unit, which is supposed to take everything together, was very poorly funded. So we're also in an quality assurance unit from, I think, Catherine Yorkin is here, what he is trying now to develop, was very poorly funded as compared to an HIV/AIDS program. And what is more important than quality of care? So that were things which in the 90s were brought back a little bit our emphasis on primary health care and CBHP, and now slowly we are trying to grow again. However, you need a proportion of your GDP from your national budget to health. And in those days, in the 70s, 80s, there was much less money, but at least 7%, almost 8% went to health. And then it dipped down to 4%, and even recently it came up. Now, more money came, it's true. So it is absolute terms, it is more money. But the population grew 3 times. When I came in Tanzania in 1974, Tanzania had 17 million people. And today we have 60 million people. And the budget has not grown from 17 to 60. And so we have an issue here that we have growth, true, is good, more revenues, but also our population is growing. And to make matter worse, our emphasis in primary health care, which we always discuss with Dr. Ntuli, is those districts which are deprived from services, the faraway districts. But Tanzania is urbanizing. In my days, 5–10% of people lived in towns. Now 30–40% lives in town. And the primary healthcare concept and the community-based healthcare concept has always been very rurally biased. For urban areas, we don't have good models for primary healthcare. We don't have good models for using community health workers in Manzese. How do you do that? On Buguruni. How do you do that? It's much more difficult to conceptualize as people live much more anonymous and much more different. So the population growth and the urbanization has to make us rethink on how we are going to implement our primary health care and not our community health workers. So now in summary then, before and after Alma-Ata in those days, 70s, 80s, where primary health care was defined, our approach to community-based care was characterized, what I would say, by solidarity. We, in those days, we feel very much solidar with the people in need. While today, the key word is competition. Now, competition and solidarity don't go together. And you have to think about it. Because competition is the way of life. Our making things evolve in the private sector, profit making, has become a big part of our being. It doesn't go together with solidarity, being community oriented, being working from here and not from my wallet. So that is again something to think about. I don't have clear answers, but we have to really think about solidarity in the past, we should learn from, and our threat in our society of competition and business orientation. Then the rural focus, as I discussed in the past, and the urbanized area in 2015, which is only in 20 years' time, more than half of the population of Tanzania will be urbanized. More than half. The majority of Tanzanians will live in an urban context. We also learned from the past a bottom-up approach, Matamora in Vumi. And now we are much more thinking about a top-down approach. Dr. Meshach designs the guidance for the whole country, the indicators, etc. Which is good, because we need to have that backbone, that guidance. On the other hand, we need also to be sure that we can reflect in our activities the needs of the people you work with, which is maybe difficult. Infertile Maasai women have different primary health care needs than people here next door, so to say. So we have to be flexible. Flexibility is a key word we need to use. So the take-home message: learn from the past. Read, go to the books, read what we have done. We have done so much. There are so many publications about Tanzania primary health care. They are in the Lancet, they are in university libraries all over the world, except Mumbili. You can't find it. You can't find the publication. So we have to compile what we know. And you guys in your project, you have to write down what we have learned, document what we have learned, so that others can learn from it. So that is, I think, learn from the past and document it, and learn from today and document it. And then we share, like in this forum. I'm very happy that we now can share this and think and reflect on this. Thank you very much.
Thank you so much, Dr. Eric Van Praag. We've had Madini, we call it Madini, wealth, from the past. Wanasema wazee wetu tuwaenzi, and we've had big names here. Who remember these names? For those who went to medical school also 20 years ago, like me, we remember we had a lot of these names, Professor Nonoli, Muhondwa, all these big names. People are doing great work, and the bottom-up approach is something that we should also continue to consider. Thank you so much, Dr. Eric. And I believe also the ministry is also putting up the platforms and policies to use those kind of approaches. So without further ado, let's go to Dr. Florence Temu. Dr. Flo, over the years, Amref niche has been to strengthen community structures for better governance and accountability of stronger health systems, as well as influencing development of effective health policies. What would you say are the learnings from this important role you would want to share? And also on top of that, what aspect of these learnings should be considered for scale-up? Karibu, Dr.
Thank you, Dr. Issa. Coming after Eric, it's another challenge by itself. And of course, also other speakers. But the question goes to Amref, Nish, and what we've been doing. And I must say that when it comes to community health programming or community health interventions, to Amref is like a DNA to Amref. And it has been there since its inception. Amref was born back 1957, 59 there. And along the years, 1960s, Amref, the founders, used to work with the Ministry of Health in Tanzania, especially looking at the community health. And the community health program, the community health department in Muhimbili University right now, it's one of the products that Amref did in terms of support the Ministry of Health, and by then University of Dar es Salaam, this was just a department. And up to now, we are actually honoring fourth-year students of community health practice who are performing well. Amref recognizes that. So it remains with us. Even the philosophy of how Amref was born is also within reaching out to people. I think you know about flying doctors. It's just the philosophy of getting out to people with specialized healthcare, etc. So that's continued with us. And one time we analyzed our data of 15 years, and we found that within that span of time, we had reached at least 7 million beneficiaries. That includes those indirect and indirectly, and majority are women and children. And that remains even now. Like last year, at least we have reached around 9.3 million beneficiaries, and again, majority are women, around 50.2%, and children also around 28%. So as we speak now, we're engaging at least 5,554 community health workers in 23 regions, both in the mainland and island. So talking of community structures, Amref recognizes both formal structures as well described by Dr. Ntuli, including the community, the village health committees, the health facility governing bodies, etc. And we work through that structure as it's been stipulated, but also recognize the informal ones. And the informal here, we refer to the clan leaders, they're also very influential, and traditional leaders within their settlement, depending. So I've been asked to share about lessons, and in doing that, our aim is just to make sure that no one is left behind. And I've pulled out at least 5 lessons. Given the history, we have so many lessons, but I just pulled out 5. First of all, what we have learned, communities are heterogeneous. And they're not the same. Much as we are all in Tanzania, we all speak Swahili, but we know we have differences in our culture, our health needs, our literacy levels, and many other social determinants. So even when you're approaching communities, you find some communities also have definition of their disease. You can come with a concept, maybe it's cancer. I met a community where they define cancer in 2 categories. We have cancers, those are natural, and brought by God. And there are cancers ambao ni jicho la mtu. Cancers are jicho la mtu, so za kwenda hospitali. But the cancers by God, these ones, okay, you can go to hospital. So before you know which cancer you have, go to the person they know in the village. So these are the people need to address as well, because they have their own way of defining disease conditions. So, but we are glad now we have a national guideline that gives us a standard. I think we have already said how fragmented it was before, but it still have to be contextualized and learn who are the influencers. In Amref, we have this program on anti-female genital mutilation and intervention. We did that in Kilindi, which is in Tanga, but also in Mara, in Miatu. These are different communities, but same intervention. And then we realized the approach that we did in different communities we are different, but of course, we managed to avert young girls out of female genital mutilation and dedicate them to school. Kilindi, the best approach is, because this is a Maasai community, is to recognize the clan, the traditional leaders and the clan. So that's how we engage them, and at least 3,000 girls were escaped from the family genital mutilation. We did the same in Mara, but in Mara we need to engage the law enforcers much more than just the community leaders. And they came up with the bylaws of their own, and you know why. And we went to Meatu. Meatu, there, as most, it was to target the head of the household. And the head of the households were more influential. Even those celebrations of family genital mutilation, he's the one to decide. So you have to point out. So all this we learn from the communities as we work with them. So I think, and as we work forward, we also learn that we have to integrate with other needs. You go with the sexual reproductive health interventions, but their priorities is actually water. So we have to do integration, WASH intervention and SRHR, so that you can all address everything comprehensively, as it has been said by my former speakers here. So lesson number 2 is the community health program, or community health workers. This is no longer debatable. They need to be recognized, and I'm very happy the way we've moved miles. Those years you cannot sit in the same room, medical doctors and community health workers, because medical doctors, they know it all. But now I think we recognize the power of the community health workers. And I'm so glad when I read Tule's papers, etc., the study did, I'm so impressed to see their health, they're integral. Community health system and the community health workers are becoming integral part of their entire health system. That's a very good achievement. And I think the challenge we are seeing now is the time it takes to formalize the source for payment, for remuneration. I think it has taken too long, and that's why programs are there, and they keep coming. Disease don't wait for you to put up the program. The things are turning up. So at the end, we have to make sure that at least, I'm glad we are moving, defining sources. I hope some time will come, because volunteering is not sustainable, though we cannot run away from it completely. As you could see, we still need to use our other informal structures. But again, feedback mechanism need to be introduced so that community health workers are given feedback, how many have referred, let's say COVID condition, how many of them were actually vaccinated, some are not, so that they can send the same message back to the households and the communities that they serve. Lesson number 3 is about the community structures and community programming. What we learned, they're essential. Whether talking about facility-based, there's, the entire healthcare spectrum, from the prevention, health promotion, disease prevention, curative, rehabilitation, community structures remain important. Our healthcare system is highly disease responsive or curative in nature. And we need to, that's okay, especially when we go high level, the referral level, high level, regional, to the consultant hospitals, up to the national level. But down here, the primary health care, I think we need to promote so much on health promotion, disease prevention as much as we can. So more of investment there is needed. So as we invest, we define incentives on the community health workers. I think it should also have indicators that bring more health promotion, disease prevention, and referrals as much as possible. On lesson number 3 is the interface that Dr. Ntuli mentioned about. We also see that the interface between facility-based and community-based is key, especially if we want to see the positive outcome of the health services that we provide in health facilities. We've seen that in our HIV and TB programs, when we have lost to follow-up, when we have to identify those who are living with HIV or undetectable TB cases. This interface needs to be narrow. To trace the loss to follow-up, actually we've seen a big number coming back because of that linkage. Separating interventions from facility and community, still we're creating so many silos. But I think we need to manage the interface as much as we can. I've seen that also on COVID response, as we have already said. I think the same can go towards the non-communicable diseases and other, because especially nowadays, we see high burden on non-communicable diseases. Another lesson number 5, which will be my last one, is on the digital equity, technology. I think we tend to think community health workers cannot use technology, or they do not understand. So we struggle so much introducing technology facilitated learning models. And we have seen that with the current, I think for digital equity, community health workers should not be left behind, including our community members. Amref, we have a program on LEAP. We've introduced this to the Ministry of Health and PURAC, they're all much aware of it, but we have lessons from Zanzibar, who have already taken up the platform, and within no time, within a month, we are able to send learning platform to at least 136 healthcare workers, community health workers, or they call community health volunteers, but they were able to reach 28,000 community members within very short time. And because this platform is interactive, so it allows that question and answers, but also a refresher to the same community health workers. This is just an example. I know there are many other platforms, but I think we should encourage digital access to our community health workers, so they can use it even at night. So talking, to answer your last question about what to do scale up, I think I'll encourage, so for continuum of care, that interface needs to be very narrow. I think that's what we're trying to do, and we are there to look at. And the financing models for community health programs, I think we need to accelerate it, test them, and see which one works best, and we adopt that. Much as know that our communities are very different, but we can also see how much to do that. And also investing on health promotion and disease prevention as much as we can. And lastly is recognizing the informal community structures as well. They are very, very influential in making health changes. Thank you so much.
Thank you so much, Dr. Florence. That was a very good insight of what Amref is doing. And because of time, we'll quickly go to Sabore. Na we'll use Swahili kwa ndugu yetu Sabore. Sabore, karibu. Huduma ya afya ngazi ya jamii ni nyenzo muhimu kuwafikia Watanzania walio mbali na vituo vya kutolea huduma za afya hasa vijijini. Na ukiwa kama mhudumu wa afya ngazi ya jamii ulifanya kazi hii zaidi ya miaka 15, nini unaweza kujivunia kama mafanikio ya kazi hii? Na changamoto gani ungependa serikali itazame katika kuboresha huduma hii ili iweze kuleta matokeo chanya katika kupunguza maambukizi ya magonjwa mbalimbali na vifo kutokanavyo na uzazi na vitu vinginevyo? Lakini pia unaweza kutoa mifano kwa kutumia katika nyanja ya kudhibiti magonjwa ya mlipuko na matukio yenye athari kiafya ambayo unajua umefanya kwa muda mrefu. Karibu sana.
Asante sana. Wahudumu wa afya ngazi ya jamii wanasaidia sana kuwafikia wanajamii waliopo katika maeneo ambayo yana uhaba wa vituo vya afya. Ninachoweza kujivunia katika kazi hii ninayofanya ndani ya jamii baada ya kupata mafunzo kwa shirika la Amref kwa ufadhili wa CDC Marekani pamoja na mashirika mengine na pamoja na halmashauri ya wilaya Ngorongoro, ambayo imeniwezesha kufanya kazi ya huduma ya afya kazi ya jamii kwa usahihi zaidi, ni pamoja na kujumuisha elimu ya afya ngazi ya jamii. Hiyo inajumuisha matumizi sahihi ya madawa ya kupunguza makali ya ugonjwa wa ukimwi na ugonjwa wa kifua kikuu, kujiepusha na maambukizi mapya ya ugonjwa wa ukimwi pamoja na ugonjwa wa kifua kikuu. Hiyo pia inajumuisha kuhamasisha kina mama kuhudhuria kliniki, kupata huduma ya uzazi pamoja na huduma salama na uzazi salama. Pia kazi zangu, majukumu yangu mengine ndani ya jamii ni kutembelea wanajamii manyumbani kwao. Kwa hapa rufaa kwa wale ambao wagonjwa, kwa sababu baada ya kufundishwa na kupata mafunzo na shirika la Amref, tulipewa dhana kama mfano kitabu hiki, hii buku tunaitembelea ndani ya jamii. Kwa hiyo unapeleka ndani ya jamii kule, unaandika jina la mgonjwa, huwa tuna fomu ya rufaa ambayo tulikuwa nayo lakini zimeisha zile, lakini hii tunaitumia kwa ajili ya kuandika majina ya wagonjwa, unaopa rufaa wahudhuria katika vituo vya afya. Kwa hiyo jukumu langu pia ni kutembelea majumbani kwa wale wagonjwa kwa ajili ya kuwasukuma, kuwahamasisha na kuwapa pia rufaa kwenye ile fomu ya rufaa ili waende katika vituo vya afya. Jukumu langu lingine ni kutoa rufaa, kutoa taarifa ya magonjwa ya milipuko kwa muda wa masaa 24. Kuna magonjwa haya kama corona, kama kipindupindu, kama kimeta. Haya magonjwa yanatakiwa muda wa masaa 24 umeshatoa taarifa kwa vituo vya afya ili iwezekane kwa ajili ya kupatikana kwamba ni kushiriki kutekeleza mikakati ya kudhibiti magonjwa ya milipuko ndani ya jamii. Mikakati hiyo ni pamoja na chanjo ya ugonjwa wa corona. Jana nafikiri mimi nilishachanja, sijui kama ni kadi yangu sijui nimeweka wapi. Nayo kadi yangu sawa. Nilikuwa na kadi yangu lakini sijui nimepoteza wapi. Nilikuwa na kadi yangu kabisa ambayo inaonyesha kwamba nilishachanja. Sawa, niendelee tu, nitatoa baadaye. Sawa. Kwa hiyo tunahamasisha kwa ajili ya watu kuchanja kwa kipindi sasa hivi, kwa sababu kuna ugonjwa ambao sasa hivi inazungumza sana katika taifa kwamba watu wakachanje. Japo ni changamoto kule kijijini, lakini inatakiwa uchanje kama kiongozi au kama mhudumu ngazi ya jamii, ili angalau utakapofika kwenye vikao unaweza kujivunia kwamba mimi nimeshachanja na kadi, ndio ni maana nimekuwa na kadi, ili angalau nikienda kwenye vikao naonyesha kwamba mimi tayari nimeshachanja. Kwa hiyo pia uchimbaji wa vyoo. Haya magonjwa ya milipuko yanatokana pamoja na watu kutotumia vyoo. Kwa hiyo watu wasipotumia vyoo kule kijijini ni shida sana. Hata kuchimba vyoo sio rahisi. Mtu yani baadhi wachache wana vyoo. Kwa hiyo pia ni jukumu langu pia kuhamasisha jamii wachimbe vyoo. Na inatakiwa kwanza wewe mwenyewe kwanza una choo, alafu ndio uweze kuhamasisha jamii kwamba wachimbe vyoo. Pia tuna ugonjwa mwingine ambao unaitwa ugonjwa wa kimeta. Ugonjwa huo wa kimeta ni ugonjwa mbaya sana. Kwa hiyo tunatoa elimu kwa watu wasile nyama ya wanyama wanaokufa kwa ajili ya ugonjwa wa kimeta. Sasa labda niende tu kwenye changamoto kwa sababu naona muda umeenda. Changamoto ambayo naweza nikatoa ambayo kwa ajili ya huduma hii ya ngazi ya jamii ni wahudumu wa afya ngazi ya jamii wapatiwe posho. Kazi za huduma wa jamii inatakiwa upeleke uzalendo mbele kuliko ubinafsi, kwa sababu ni kazi ngumu sana tunafanya katika mazingira magumu. Kwa hiyo inatakiwa ningeshauri serikali angalau basi watu wapate posho, wale huduma ngazi ya jamii pamoja na hata wadau wa mashirika mbalimbali waweze kuchangia hizo posho, angalau huduma ngazi ya jamii waweze wapate hizo posho. Lingine, hizi taarifa zetu kama hizi sasa hivi za kwangu ni kwamba ziko kwenye karatasi ambazo zinaweza zikalawa kwa mvua, kwa sababu tunatembea katika mazingira magumu. Kwa hiyo tunataka labda mfumo huu ipitie kwenye elektroniki angalau basi na sisi tuweze tukapata kwamba sehemu za kuhifadhia hizi taarifa ili isiweze kuharibika. Kwa hiyo nashukuru sana. Naona muda wangu umeenda, kwa hiyo nashukuru sana kwa hilo. Asanteni sana. Asanteni sana.
Asante sana Bwana Sabore Eliza kutoka kabisa vizuri kabisa the real CHW anafanya nini. So from the top to the bottom up, what are the challenges etc. Muda umeenda. Naomba ni watu waulize maswali. Tuanze maswali matatu ya haraka sana kama tutaweza alafu niwape sasa wale wenye mic nitawapelekea, kuna mikono kule. Kuna yule kaka pale, naomba mumpe haraka chap chap. Alafu tutachukua maswali matatu alafu watajibu. Yule pale, kuna mmoja yule pale. Halafu kuna yule kule nyuma naye alinyosha sana na yule katikati pale.
Okay, thank you so much. My name is Sayuki Mfinanga, and this program is very interesting. You have said a lot about the community platform. It has been growing for many years, and it seems that it's somehow well set to manage communicable diseases at the primary level in the community. But my issue is, recently we have seen a huge increase in chronic conditions, non-communicable diseases. And these are chronic conditions that people live with them. I'm not quite sure how much the community health program is well prepared to handle this, because this is complicating the communicable diseases. We know that it has a tendency of occurring in comorbidity trends. We have seen recently that people with underlying conditions like diabetes, hypertension, and others, when they get COVID, the situation becomes serious. We have seen non-communicable diseases increasing among people living with HIV and complicating health outcomes. I will appreciate comment from any of you in terms of what can we do to have an integrated chronic care services at the community level. That is my only question. Thank you.
Thank you very much. My name is Samuel Imara, and I'm the District Medical Officer for Iringa DC. First of all, I want to congratulate the panelists for their thoughtful engagement in what they are presenting. Actually, I have an advice and then probably a single question. My advice goes to the policymakers and my colleague, my brother, Dr. Ntuli. While you are coming up with a new guideline for engagement of community healthcare workers, I think we should also revise on the health financing system. We are having big challenges when it comes to health system financing. And as we are talking of sustainability, I think we cannot continue relying on the donor funds as you all agreed. So the only way we can have the funds to sustain or to support the community healthcare workers is for the health facilities to be able to collect and support all other activities, including those which are related to community health initiatives. My colleague, Dr. Msiba, talked about the 5% from the CCHP, but if you scrutinize our plans, our CCHPs, you find that probably more than 50% of the funds are donor originated. The health sector basket fund You go in there, you find that there is UNICEF and some other social funds that are not internally generated. So you find mostly the funds we have is the OC, which is not reliable, and then the funds from the insurance.
Can you summarize it because of time? Yeah.
So I would encourage that we have a new guideline on healthcare financing system. But my question is, what is the role of the political leaders in supporting the activities or the efforts that are put forward by the healthcare providers? I'm asking this based on what we experienced when we had the Uturo model.
Okay, thank you very much. I think the question is clear. Because of time, we need to have one hand from a lady. There's a lady, kule nyuma. Please, we have a mix. Melody. Okay, Melody. And then we'll have a quick response because of time. We're very, very sorry.
Hello, good morning, everyone. So I really wanted to acknowledge, like my other colleagues, excellent panel, Hongera sana Aisa and the team. My comment is very simple. I really wanted to just share. We know in the regions whereby they are fully supported by a partner when community-based programming is concerned. They are doing very well in different indicators. My challenge to the ministry and PRLH, how can we replicate those best practices to other regions with minimal cost?
Thank you very much. Now we will have responses. I think Dr. Ntuli looks like these are for you.
Thank you very much. Actually, they are very beautiful questions. And starting with Professor Hanang's question, in the new guideline, we have 5 to 8 modules, one of which is on non-communicable diseases. So we are kind of trying to integrate these interventions. Initially, they were verticalized. The system were fragmented. But as far as the new guideline is concerned, it's trying to harmonize all the fragmentation which we had before. So we do not want the community health worker to work in silos. So Mr. Liza will be provided the training to these different modules. That's why I was speaking of the issue of water-related diseases, the outbreaks, and also the COVID. So we want our community health workers to be able to engage into different interventions without any problem. So with that one, there's no any challenge in the meantime, and we hope working together with our implementing partners, we'll be able really to help our community health workers to be very comprehensive in terms of their skill set and other things. And going to Dr. Mara's question, that's quite a very important question. The healthcare financing with regard to the community health system has been the challenging part, but with the revised comprehensive cancer health plan, we have increased the budget for the community health system. Initially, we had fewer priority areas. Now we have 14, one of which is on community healthcare system. But for now, we are kind of trying to discourage our implementing partners from dispersing or incentivizing the community health workers without the knowledge of the government. So we want to employ the direct facility financing approach, which was launched in 2017. So the funds will come from the Ministry of Finance and Planning or from our implementing partner. We'll go through the government system, and they will be dispersed up to the primary health facilities. So we want to use the primary health facilities as a reference point, because it's through the primary health facilities where you can be sure of the accountability. We have learned with 2 implementing partners. They were dispersing the funds with CHWs via the M-Pesa. And these CHWs, they were not reporting to the facilities. They were not visiting the households. So there were no accountability on that. So we want them Upon submission of their reports, upon the interface meeting, is when then we should be able to remunerate. And so I agree with you that we really need to look at the healthcare financing approach. But next month we shall be tabling the bill for universal health insurance. We believe from that the number of challenges will be addressed. I'm also a believer that we should not be over-reliant of the foreign money. Instead, we should be able to generate our own money. And we have been able to do that tremendously the past 2 years when we introduced the improved community health fund. Initially, we were collecting up to 3 billion per year. But as I'm speaking to you now, with the improved community health fund, we have collected 23 billion Tanzanian shillings. And I can also view the collections across the country in the real time. So with improved community health funds using what we call the insurance management information system, one can track the finances across the country. We have more than 6,000 primary health facilities across the country. So you can get that financial report in real time. For me, that's a huge, huge progress that has been made by the government. Now going to Rosemary's questions. Mary Rose's questions. Well, we have Professor Finanga from NIMRI. We have other colleagues like Eric and others. It's through collaborations we can do better. We need to document from the government side, from the non-state actor side. I, together with Eric, we are writing a book on the evolution of primary health care in Tanzania. 70 years before independence, 61 years post-independence, and we want again some other years, maybe around 1 year after independence. So we believe from there then we'll be able to document all what happens in terms of the primary health care in the country. So we invite you over to join us in this very huge undertaking. Hopefully next year in the same room we shall be able to show you the book on the evolution of the primary health care in the country. Thank you very much. Maybe now parafiki yangu pale, Liza. Ni muhimu changamoto ulizosema namna ya kutumia electronic. Tunafanya kazi na wenzetu wa Amref na Benjamin Mkapa. Kuna baadhi ya vitu tunajaribu katika eneo dogo. Na sisi tunapenda tuame kutoka kwenye eneo la kutumia makaratasi na tuende kwa kutumia mfumo wa electronic, kwa sababu na sisi inakuwa ni rahisi kufanya tathmini za haraka na kuleta mrejesho kwenu. Kwa hiyo naamini kwa kufanya hivyo tutafanikiwa. Ila kuhusiana na swala la malipo kwa community health worker, ni kwamba tayari tushaandaa mwongozo. Mwanzoni ilikuwepo watu wanatoa 300,000, mwingine anatoa 200,000, mwingine anatoa 100,000. Sasa hizi tuna kiwango kinachofanana. Lakini tutapenda mpokelee fedha kupitia vituo vya kutolea huduma. Kwa sababu kuna wadau wetu wawili mwanzoni walitoa fedha kwa kupitia M-Pesa, Tigo Pesa na nyingine. Ilionekana kumbe wale waliowapa huduma wa afya ngazi ya jamii walikuwa wapeleki ripoti vituoni, wala wengine walikuwa waendi kutembelea kaya. Kwa hiyo tukaona huo utaratibu unaweza kutuletea shida baadaye. Kwa hiyo wewe ukifanya kikao na kituo cha kutolea huduma, na nyie sasa hizi tumewaingiza pia kwenye zile kamati za uendeshaji wa huduma za afya za kituo, ni sehemu yenu, na pia mtaingia kwenye mwongozo mpya kwenye ODC, mtakuwa na mwakilishi mmoja, na ninyi pia mtakuwa mnawasiliana kati ya ninyi na kamati au bodi ya afya ya halmashauri. Tunataka kuwepo na mwendelezo wa mfumo wa afya kupitia. Na sasa kazi nyingine tunayofanya na Amref, tunakusanya namba zenu zote za simu na vitu vyote, anwani zenu nchi nzima. Ili kwa mfano kama sisi tuna ujumbe kuhusiana na uviko 19, basi unashangaa laiza imeingia message pale kwamba tunaomba usisitize kuhusiana na masuala haya, ili mwisho wa siku tusiweze kupata changamoto za utanza na uviko. Ila nakushukuru sana, uwasilishaji wako ulikuwa mzuri sana, nimefurahi sana.
Asante sana. Thank you so much, Dr. Ntuli. We are running out of time. This is a very exciting topic. I know many people will want to ask questions. Participants, we're going bado hapo kwenye conference. You can meet later over the tea or the afternoon and continue to discuss and break down what can we do better. So niwashukuru sana for attending this session. It has been very short but very fruitful. A lot of information, very good information. We commend so much the efforts of government. Dr. Ntuli, please send us our affirmation and compliments to the Ministry of Health, the Ministry, the Pure Large, for the great work and consideration they are doing to revitalize the community health system, strengthening, as we are now entering to the era of universal health coverage, leaving no one behind. You can hear that every citizen matters, and everybody matters. So we should not leave anybody behind. We heard yesterday, and we continue to hear this information throughout our conference these 2 or 3 days. So thank you so much, and have a nice day. And thank all the participants, the speakers.
Excuse me, sorry. Just want to make a few announcements before you leave. So it's time for breakfast. The breakfast will be provided just outside the hall to the left, and after which at 10:30 we have a session at the main hall, the first keynote.